Well, good morning. We're going to sweeten up the lecture program and talk about sugar. Hypoglycemia is one of those problems that just doesn't seem to go away. You would think that after all of the years that we've measured glucose concentrations, going back to the early part of the last century, we would have solved the issue of what glucose concentration is too low, because that concentration or below leads to irreversible brain injury. Unfortunately, that's simply not the case. There's been little progress made because the long-term outcomes in infants with only 1 or 2 low blood glucose levels have become the grounds for lawsuits, legal issues, and that's particularly true in the United States. We happen to have a very active tort reform, lack of tort reform, and a very active tort system, meaning if there's something that can go wrong, a lawyer can sue you for it. And unfortunately, they have picked on hypoglycemia in the last many years to take care of try to resolve this problem. The definition of clinically significant hypoglycemia, therefore, remains one of the most confused and contentious issues in contemporary neonatology. So let's go back to the early part of the last century when glucose concentrations were first measured. And in 1937, there was an article from two physicians in France, Hartmann and Jourdain. They reported 9 neonates out of 285 infants and children with varying degrees of severity of low glucose concentrations. And they weren't the first to use the word hypoglycemia, but they used it in this manuscript. That's the first that I could find that it applied to neonates and very young children. And they found 3 groups of glucose concentrations. Those that were considered mildly low, therefore called mild hypoglycemia, 45 to 50 milligrams per deciliter of true sugar values, and divide by 2, that's the closest way to come to, or by 20 to come to millimoles. Moderate, 20 to 40, extreme, less than 20. And for those of you who use these numbers, 20 would be about 1 millimolar. How many of you would say today that extremely low glucose would be less than 1 millimolar? Most everybody would. And moderate, okay, 1 to 2 millimolar. And mild, 2 to 3 millimolar. I think we'd all agree today, after almost 100 years, that these really are fairly accurate representations of how we would view the concentrations of glucose in newborn infants. So, as you can see, we haven't made a whole lot of progress. The same values continue. It's just we attach different problems to them. Over about 75 years then, 75 neonates with similar presentations of symptomatic hypoglycemia had been reported. So that's a long period without a lot of reports of what we would call symptomatic or significant hypoglycemia. These were predominantly male infants. They were born small for gestational age, most of them having suffered intrauterine growth restriction, and they were commonly found in mothers from pregnancies where mother had preeclampsia or even eclampsia. And they all had the following sorts of clinical signs. Most of them had episodes of tremor, irritability alternating with lethargy and hypotonia, occasionally apnea and cyanotic episodes. They would feed poorly after initially feeding well. Some of them became hypothermic, and they had changes when the glucose concentrations were very low for longer periods, hours, not minutes, in levels of consciousness, progressing to seizures and even to coma. They all had laboratory blood or cerebral spinal fluid glucose concentrations that were less than 1/2 millimolar to just over 1 millimolar. Of note, the symptoms and laboratory values recovered promptly with treatment. Treatment raising the glucose concentration to above 3 millimolar. And that was with or without any kind of other pharmacological treatment. And these symptoms, once corrected, did not recur, nor was there evidence of long-term sequelae. So where did the idea come from? With this beautiful clinical presentation that we all would say, yes, that is serious hypoglycemia, that led to permanent, irreversible brain injury. That came from animal models, not from human studies. So as a result of these surveys, the consensus was that even extremely low glucose concentrations were of little to no significance because they occurred with and without symptoms. They were usually transient. They were easily corrected, and once corrected, they were not associated with long-term neurodevelopmental outcomes. That actually, when you review the old literature, going back to the early part of the last century, is exactly what is the case. So, as I say, where did the problems come from? Well, part of the problem came from people like me and my colleagues who have gone around the world saying to everybody, you know, we really need to keep glucose concentrations above some abnormal, some arbitrarily defined value so that we can prevent the serious long-term complications of hypoglycemia. Having bypassed the whole issue that except for some significant animal model studies, it was almost impossible to find in the literature clear evidence that this kind of hypoglycemia in newborn infants could cause this kind of irreparable long-term injury. And then the endocrinologists got into the story, and I think this is where things really actually became much clearer, but as well as more confused. And I'll go through that. So in 1999, an endocrinologist in Philadelphia, very good friend of mine, simply wrote an article in the New England Journal of Medicine proclaiming that all neonates should be treated no differently from anybody else. The normal glucose concentration that everybody has after a few hours of life is above 60 milligrams per deciliter, 3.5 millimolar. And therefore, there should be no reason to allow a baby to have a lower glucose concentration. Now, this was an endocrinologist who had never worked in the neonatal intensive care unit in his life. So he just didn't simply pay attention to the fact that all babies after birth, once the umbilical cord is cut, have a fall in glucose concentration. And then natural phenomenon raise the glucose concentration up and babies start regulating it to values that, yes, by 2 to 3 days of life, generally are above 50 to 60 milligrams per deciliter. So to date, even this endocrinologist has found no reason and no evidence to support that contention that we should have initially in the neonatal period glucose concentrations always above 60 milligrams per deciliter. In fact, that would revolutionize neonatal medical practice because every single baby would have to receive an intravenous of glucose. And every mother who's breastfeeding would have to stop immediately and have her baby put on an IV. Well, that's nonsense. So why are the clinical signs of hypoglycemia so variable and lead us to these difficult correlations between what we see and what we think is going to happen if these symptoms get worse? Well, first, all of those symptoms that I showed you are really very nonspecific. Every sick baby acts exactly the same way. And so there was nothing unique about being hypoglycemic that you could say, aha, the baby is having that kind of tremor or that kind of hypotonia, and therefore that baby is hypoglycemic. Because you find those same symptoms with sepsis, hyperbilirubinemia that's severe, and just about every other condition that's out there. They're variable. There's variable presence of alternate substrates. So even if glucose is low, the average normal baby has an increase in other substrates like ketones and lactate, which are very nicely taken up by the cerebral circulation, delivered to the brain, and used as alternate substrates. So just having a low glucose does not mean your brain is deprived of the only energy source available. Then there's differences between short and long-term adaptations, and I've gone through that already in my talks, where short-term you can have a deficit of glucose and some neurological symptoms associated with it, but longer-term you start seeing upregulation of the capacity to take glucose up from the cells, from the plasma, and put it into cells. So symptoms could come and go as glucose concentrations and the capacity to take up glucose into cells changes. And then there's lots of variable physiology associated with any one glucose concentration. you can have a high or low hematocrit. And if your hematocrit gets higher, then there's less plasma in the blood going through the brain. And less plasma, therefore, means less glucose, because glucose is primarily carried in the plasma. So cardiac output could vary. Blood pressure could vary. So lots of things could contribute to variable delivery of glucose to the brain. And there could be intermittent hypoxia ischemia. Lots of glucose disorders are associated with hypoxia ischemia, and that, as you well know, has its own set of complications leading to symptoms. There's just an example of the neonatal ketones versus gestational age. The younger the baby happens to be, the more immature, the less adipose tissue the baby has. So even if this baby has active lipolysis and tries to break down the fat to produce fatty acids that could be oxidized into ketones, which could then be used by the brain, there's just not enough of that around. So the very preterm baby is going to be at risk when there's less glucose because there's less alternate substrates. But you can see that over the second half of gestation, there's high variability in the supply of ketones, and therefore you could imagine major variances in how this might impact neurological outcome. This is just another picture of adaptation. This is brain tissue and glial cells after prolonged hypoglycemia in an IUGR rat model. That's lung tissue and fibroblasts, so you can see the brain has preferentially developed the capacity to maintain glucose transporters and therefore the capacity to take up glucose despite low glucose concentrations, whereas other tissues that aren't quite so urgent in their need for glucose don't have this capacity, or at least have less of it. So another example of adaptation, this is the one that I showed you yesterday, the upregulation of every region of the brain for glucose uptake capacity. So what have we done about the concentration of glucose, now that I've given you some examples of why this has become such a controversial issue? Well, what we've done is simply, along with our colleague from Philadelphia, the endocrinologist, change things arbitrarily without any evidence. So there we are back in the early part of the last century and clear up through the 60s, late 60s, saying that values as low as 20 were okay, values below that maybe not okay. And then people started looking at babies and saying, you know, if we're going to say that's low, maybe we ought to say that you ought to keep the glucose above a value twice that. Twice? Why? Well, somebody just wrote it in an article. I don't know why they chose twice, but that would allow babies to occasionally drop down into this range without going below that. So it's sort of like a safety factor. The other reason I think that this really became a value, of interest is that if you look at the earliest glucose reagent strips, those little glucose oxidase strips that you used in the nursery, and many of you still do, to measure glucose concentration, were totally unreliable, less than 40. They had sometimes, some of the different products actually had readings that would say 20 or some value like that. But when tested, and I've studied this myself and published on it, when tested, there was no accurate value below 40. So another reason, maybe practically, why we'd say, okay, if we can't measure it at the bedside less than 40, let's just say if it's less than 40, it's not normal, and then measure it in the laboratory and get on with things. Well, why 40? Well, once that got entrenched, then people said maybe it ought to be a little higher so we don't have to deal with this problem very often. You know, because we were measuring lots of glucoses that maybe were less than 40. And it became an annoyance. So we said, let's make it a little higher. And I just put 48 down because I took that out of one of my papers. Not very well justified. But there were many in the high 40s to low 50s. Again, I think purely arbitrary and purely based on this concept that you're trying to avoid a range that's not accurately measured at the bedside so that you don't get down to values that are extremely low and therefore run into problems either with abnormal babies or bad lawyers. Then the endocrinologist came along and said, you guys are just missing the boat. If you're all aiming towards a value higher than that, let's just look at normal children. They all are above 60, so let's set 60 as the lower limit. Purely unjustified. So you can go to the literature. That's the endocrinology statement, 70 He raised it when he put it in a textbook. When he wrote it in the New England Journal, it was 60. No reason for putting the 100 in there. Here's Dr. Calhan, 36. Dr. Ogata, less than 40. And Dr. Jane McGowan and myself, we were somewhere in the 40 to 45 range. Absolutely, totally arbitrary, with no scientific rationale. In fact, no clinical justification either. So why are we talking about glucose concentration? First, because there is some value to knowing what the glucose supply to the brain is. Brain glucose uptake rates in neonates are extremely high. 5 to 7 micromoles per 100 gram of weight per minute translates into about 4 to 5 milligrams per minute per kilo of body weight, which, as you know, is about 75 to 90% of the entire glucose utilization rate by that baby. So almost all of the glucose produced by a baby's liver, or the glucose you infuse intravenously, is going to go to the brain. So glucose supply to the brain is quantitatively very important. And as I already pointed out, if you don't have subcutaneous fat, you're not going to be able to produce alternate substrates very easily. Why is glucose concentration important? Well, there's lots of studies clinically that suggest that there's some value to this. So these are babies that, actually this is an animal study, and this is a cardiac carbohydrate of different species of animals and survival during anoxia. So they simply put these animals, these neonatal animals, into a chamber that had 0 oxygen. And this is the mean survival time, so 10 minutes, 20 minutes, 30 minutes, 40, 50 minutes, how long the animals survived. And that's the starting concentration of carbohydrate in their hearts. So the heart would stop functioning, go into asystole, and the animal would die much sooner if there was no carbohydrate. So the IUGR fetus that had very poor carbohydrate concentrations in its heart was much more susceptible to cardiac arrest and death than an animal that had a much higher concentration and had not been IUGR. Then I point out again that in humans we have another unique problem. Not only do we have a very high glucose utilization rate for the brain, but the brain in our human neonates is a huge, large fraction of body weight compared to all of the other species, and that the neonate is particularly blessed with a very large head and large brain. So that's the brain size, that's the body, the adult size. As adults, we have a smaller head per body size than our neonates do. So same in all of the other species, but uniquely so in the human. Then there are reports in the literature, as people started looking into the problem, of long-term complications. This particular study followed up infants with reasonably well-documented hypoglycemia. Most of these were values anywhere from 0 to the 20 to 30 range milligrams per deciliter, so 0 to 1 to 1.5 millimolar. And when you looked at this group of infants, and among them there were some with neurological deficits plus seizures, at the time they had hypoglycemia. So these were sick infants with significant clinical signs that could be associated with neurological complications. And 38% of these were normal, and 50% were abnormal 1 to 4 years follow-up. And among those with the neurological deficits but no seizures, so now we're starting to discriminate, significantly ill but not with severe neurological complications, 76% were normal, 3/4, and only 12% were abnormal, and the few in between were uncertain. And those with no neurological deficits, so the asymptomatic infant, they could find practically none that had significant long-term complications. They really didn't say at all and had no way of determining, since it was a retrospective study, whether these low glucose values were the reason why these infants had these long-term neurological complications. Could have just as easily been hypoxia, ischemia, sepsis, or some other difficulty. I won't go through all of this, but I refer you to the textbooks. There is very good evidence in neurological cell cultures or animal studies for how very low glucose concentrations sustained over hours, not minutes, or in cell culture over many minutes, not just a few seconds, leads to mechanisms that produce insufficient energy metabolism in neurons so that they become disrupted, they swell, they burst, and they die. That's very obvious. All neurons, like all cells, require energy across their membranes in order to take in and put out ions. If you disrupt that energy transport process, the cells swell up, they burst, and they die. So you can produce cellular death as well as damage if you have a low enough glucose concentration around a cell for a long enough time. And I'll let you go through that because all of you know this, right, from your biochemistry days. You remember this. It was on your Biochem 101 lecture. Well, why do we focus on glucose concentration? I mean, the main issue that we ought to be looking at is glucose delivery to the brain. And that's because we cannot measure very easily brain, blood, or plasma flow. We don't do that in the neonatal intensive care unit. It would be nice if we could. There are some studies with neuroscopy that are getting at measuring blood flow in the brain, but that's global flow, not selective flow. If you look at a single artery with very high resolution neuroscopy, you might be able to say, well, the cerebral artery flow is increased or decreased, but you're still not really measuring cerebral blood flow to all of the neurons, and therefore we really can't look at glucose delivery. We can't measure brain glucose uptake easily. I can do this in the laboratory, but I can't do it at the bedside. And brain glucose uptake is dependent on plasma concentration anyway. All glucose transporters function by saying it's just easier to get a glucose concentration across the membrane. They don't actively transport it, so they don't pump glucose uphill. They just say, we're going to make it easier to go downhill from the higher concentration in the plasma or the extracellular fluid to the intracellular region. So it makes sense to know what the glucose concentration is in the plasma because the higher it is, the more likely glucose is going to go into a cell. But unfortunately, the correlations between concentration and all of these clinical problems that we're talking about is really very poor. So it's a very good measure in a cell culture model. It's a very inaccurate and very poor measure clinically. Why should we therefore define hypoglycemia? Well, almost all symptoms caused by low glucose concentrations improve with treatment. So if you know the baby's symptomatic and you give glucose and the glucose concentration goes up and the symptoms go away, it's very easy to say those symptoms were probably related to the low glucose concentrations. And then there are organic causes of hypoglycemia or insufficient glucose supply to cells that really can lead to major serious complications. And this is where the endocrinologists and even our cardiology friends come into the picture. So here is where the endocrinologist from Philadelphia is really quite correct. And really, I think what he was trying to get at is just this, that we don't want to miss these serious metabolic disorders because these are the ones that do produce brain damage. And so if we see a baby with a low glucose concentration, particularly one that's symptomatic, we need to remember that these problems could cause trouble. And you don't want to send these babies home saying, oh, that was just a low glucose, the baby will take care of that. These are the ones we want to find before they go home so they don't come back having had severe prolonged hypoglycemia with seizures, coma, and brain damage. Hyperinsulinism is probably the most common of these. Many of us annually still see babies with genetic hypopituitarism. And then there are the metabolic blocks. These are rare but very serious, and they can present in the neonatal period or several weeks of life, even up through a year or two of life. These are primarily the fatty acid oxidation disorders. If you don't have the enzymatic capacity to take a fatty acid and oxidize it, you then have to rely entirely on glucose for energy supply. And if you run out of that glucose, use up all your glycogen, you now are energy deficient, and all sorts of cells get sick. And then there's observational studies. These are so-called evidence. These are observational but not controlled or prospective. of apparent neurological injury from severe hypoglycemia. Just like the Koivisto study, if you look for these, you'll find them. If the baby had severe, protracted, recurrent neurological conditions such as seizures or coma, we all know these babies are extremely ill. And if these are associated with glucoses that are less than 1 millimolar, and these last for hours, not minutes, it's very common that we'll see later on in life that these babies are within the groups of babies that have cerebral palsy or significant learning disabilities, behavioral disorders, and perhaps even recurrent seizures and mental retardation. The prognosis still remains uncertain. Data is limited, hard to get, retrospective, difficult to choose controls. Nobody does a controlled study. We aren't going to go out and actually say, let's have babies with glucoses less than 20, and we'll even leave them there for a while to make sure they really are the part of the problem, and versus normal babies. We simply don't do those studies. The animal studies, well, it's hard to get something like that funded because everybody knows low glucose is going to cause trouble. So we're having trouble getting any more accurate research data. And then if you take an animal model and you simply lower the glucose, so for example, my colleague Dr. McGowan infused insulin into neonatal piglets. She did this for 2 hours before she achieved a low glucose associated with an isoelectric EEG. This is not an EEG doing this, this is one that's doing that, almost brain dead. And at that point, 2 hours of an isoelectric EEG, that's when she could then do an autopsy and show some changes in neurons suggesting cell death, so the sign of irreversible injury. So some animal data actually points to how these problems can lead to permanent injury. So now look at the other side of it. Why should we not define neonatal hypoglycemia? And that's because there's been no prospective, nor will I think there be a prospective study to assess the risks of any one glucose concentration or values below that for any duration or associated with any other kinds of conditions that are in a population of sick newborn infants or any other kind of newborn infant that is going to tell us what that glucose concentration is going to do in the midst of all of those other clinical correlates for long-term developmental outcome. I won't go through that because that's simply my definition of hypoglycemia, and my definition is there is no definition, which is not very helpful to you. Another group, Marvin Kornblath, Jane Hawden, and so on, they got very angry at this article in the New England Journal by the endocrinologist, and so they came up with operational thresholds. I throw this out for more historical reasons. I don't know that any of us really go around the nursery talking about operational thresholds or treatment targets. The point is, an operational threshold is a value of glucose at which or below which you ought to say there might be a problem. And you start looking into the problem, you start looking at the baby more closely, you order follow-on glucose concentrations, and when appropriate, for example, if the baby's symptomatic, you provide some treatment. If it's a healthier baby, a bigger baby, you feed the baby. If it's a smaller baby, you may start an IV. A treatment target is a value higher than this operational threshold. Obviously, you don't want to just get to where you're now saying, I ought to be concerned. You want to get above that. But they really didn't define what that target should be. That they left up to the clinician. And the concentration at which organ damage occurs irreversibly, they had no better idea than anybody else. They simply were providing a rebuttal to the endocrinologist saying, let's just be rational about this. Lots of babies have low glucoses, so let's measure the glucose when we think there's a symptomatic baby, and then let's do something like look at the baby and figure out what's going on. I come at it from a different perspective. I just say, so what happens most of the time? These are the concentrations of glucose in the normal human fetus over the second half of gestation. I've shown you this before. Almost all of these babies, almost all of the time, have glucoses above 3 millimolar. So I say, fine, 3 millimolar is the lower value of normal glucose concentration range for a normal growing human infant as a fetus or therefore a neonate. Now that doesn't say anything about transient drops below that. It just says, fine, statistically, you're going to be above this most of the time. So in that regard, I'm almost in sync with the endocrinologist, but he and I disagree about the range down here when it's transient. Here's the issue after birth. Right after birth, most babies have a low glucose concentration. That's the lower, these are 95th percentile confidence limits, I think, yes. So that's the lower 95th percentile confidence limit. That's about 25 to 30 milligrams per deciliter. By 4 to 6 hours of age, it's up above 40 to 45 milligrams per deciliter. Somewhere by around 24 to 48 hours, we're getting up to the 40 to 50 to even 60 range. And that's what the normal baby does. These were lots of babies measured with a lot of different glucose concentrations. Then we get confused because in response to a feeding study, and I've shown you this before, Dr. Alan Lucas, quite a few years ago, looked at those preterm infants who had more frequent glucose concentrations, so only 1 or 2 low glucoses, and then more and more and more. And he defined a low glucose as less than 2.6 millimolar, about 48 milligrams per deciliter. And as he looked at those with more and more low glucose concentrations, on 18-month follow-up, mental and motor development decreased. Longer-term follow-up, even into adolescence, shows that these curves flatten out. And it's been almost impossible to show any neurological deficit in this same group of infants as older children and adults. So maybe there was a problem. If this was a retrospective study, maybe it was not so severe that it couldn't be compensated for by further development, education, training, and so forth. Or maybe it's that all of us get dumber as we get older, so that idea that we all move to the mean of a lower IQ. Well, somebody else didn't like that study and did a prospective study. This was another group from England, so same country, same general population of newborn infants. They were preterm infants. These are the index cases in light blue, and in gold, those are the control infants matched by what was the next normal infant in the nursery when they identified a baby with low glucose concentrations. They didn't provide any rationale for treatment. These were simply babies identified as having low glucose concentrations versus those that did not. And each one of these is a developmental test, and you can see that and follow up whether you were low or normal in your glucose concentration. In contrast to Dr. Lucas's study, this prospective study found absolutely no difference in long-term follow-up. This study was done about 10 or 12 years ago now. It's still not published. And it's not because it has been not accepted for publication. Dr. Tin simply has been too busy and hasn't published it. I hope he does. What are the complications of asymptomatic hypoglycemia? Well, I think as you can see, they may be slightly controversial if you look at the Lucas study, but they are not controversial if you look at the previous study that I just showed you. For the most part, no one thinks that there's any abnormal neurological outcome with transient, asymptomatic low glucose concentrations. There are those who, if you take all of these babies and compare them to an absolutely normal group of term infants, will find among those that had occasional hypoglycemia that was transient but asymptomatic, some infants with some neurological complications. And that's the controversy. Are those because those were just a mix of babies and they happen to be babies that could be sick, and when you're sick you don't eat as well or you don't metabolize things as well, your endocrine system is not as normal, so you end up with more problems with hypoglycemia? I don't know. The one thing that is perfectly clear is that there has never been a study by anybody that has shown that these same low glucose values in an asymptomatic infant who is breastfeeding has any long-term neurological complication. So I would encourage you to never assign hypoglycemic injury to a baby who is breastfeeding and has transient low glucose concentrations. Look for another cause if that baby has neurological complications. Furthermore, when low glucoses have been found in asymptomatic babies, breastfed or not, there's been no follow-up that's shown any abnormalities if those babies were treated versus not treated. So obviously, no problem don't worry about it. So what is the key treatments? The first is to anticipate and prevent. That's always what we need to do. So you look at the risk factors for low glucose concentrations: preterm, IUGR, infant of a diabetic mother, history in the family of hypoglycemic episodes, of endocrine disorders, and we could go on and on. If you identify early the infant at risk, measure glucose concentrations if the baby comes asymptomatic, encourage the mother to feed sooner, provide feeding sooner. All of this really is all that we're going to have to be able to do. There's some maternal conditions. You know all of these. Diabetes, preeclampsia, previous large infants suggesting diabetes. Mothers who are drug abusers have babies with lower glucoses. Beta agonists, that's an excessive stimulation of the beta adrenergic system, which breaks down glycogen, so you could end up with less glycogen. Treatment with oral hypoglycemic agents becoming more popular for gestational diabetics. Some of these can lead to complications in the baby. And then late antepartum to actual intrapartum administration of IV glucose. This is really much more of a problem in the diabetic mother. If you get her glucose too high, you stimulated insulin from high glucose in the fetus. You stop delivery of glucose to the baby by cutting the umbilical cord, and now the baby has a high insulin, suppresses glucose production, and the baby's glucose falls very rapidly. Those are all of the neonatal conditions. We could go through all of those at another time. Guidelines for monitoring. Healthy full-term infants born after a normal pregnancy, especially those that are breastfed, do not measure the glucose concentration. If the mother is breastfeeding and everything's going fine, do not measure the glucose concentration. If the baby is high risk or symptomatic, and probably both, then there's all kinds of algorithms. This is the one that Dr. McGowan and I published. It fits pretty well with what the newer American Academy of Pediatrics guidelines show. If you're symptomatic and have a glucose around 1 to 1.5 millimolar or below that, then there's reason to pay attention to this baby, to do a diagnostic workup, to ensure that if the baby can feed, that it does, and if it has any symptoms developing, that you go ahead and start an IV of glucose. I am always very helpful to people who say, let's go ahead and start the IV, because I think in most situations that's very simple to do, and then you can let the baby develop its own feeding pattern on its own and not worry about whether it's going to feed the next time, or whether if you feed it, it will have emesis, and all of these things that might lead to, well, 2 hours later the baby's not gotten any better. But any one of those patterns is perfectly okay. So this is my quick and easy guideline for treatment of low glucose concentrations. Less than 40, pay attention. If it's less than 40 and the baby, so that's just around 2 millimolar. If it's less than 40, pay attention to the baby. If the baby's fine, go ahead and feed the baby. You can use milk or formula. If you're worried because you aren't certain if the baby's symptomatic or not, glucose gels, the kind that we can stick in the corner of a baby's buccal mucosa, they work very rapidly within a minute or two. They're very good. You can find these in most of our pharmacies. If the baby's at risk and has a very low glucose concentration, and especially if the baby's symptomatic, just start an IV. And then let nature take its course. Once you correct the glucose, go about feeding the baby in a normal pattern, and hopefully very quickly you can wean off the glucose infusion and get the baby onto a normal feeding pattern. Obviously, if the baby's even sicker than that, then you maintain the baby on intravenous treatment and start feedings as best you can, as we've been talking about for several days now. And I use target glucose concentrations. I'd like to see it above 45. Does that mean I know that if it's less than 45, injury is occurring? No. This is, again, arbitrary. It's just to give you something to shoot for. And above 60, well, that's what you eventually get to, so that's what you'd like to see the baby have, close to that, most of the time before you send the baby home. I'll come back to that point in a minute. This are the new guidelines from the American Academy of Pediatrics. They follow the kinds of guidelines I just suggested. It's what many people practice. As soon as this was published, the phone started ringing at the Academy's office, and it hasn't stopped ringing since. And I think that's largely because most people are scared that they're going to miss a baby with these lower glucose concentration guidelines. They've been burned by the gentler and kindler approach to treating hyperbilirubinemia, where if a baby were breastfeeding, bilirubin concentrations were allowed to go into the 20 to 30 milligram per deciliter range without treatment, and suddenly cases of kernicterus started showing up. So I think the pediatricians in general practice are very concerned that this is putting them at risk for missing something that then they will be liable for, and they may have caused injury to a baby that they could have prevented by simply providing more aggressive treatment. So this has become immediately controversial, even though it follows the literature and the scientific rationale for whether glucose concentrations in these ranges for these durations are a problem or not. There's lots of adjunct therapies. You don't just have to give glucose, but most of these are reserved for very significant, complicated cases. Corticosteroids have always been successful in babies who are simply slow to start producing glucose. They do two things. They upregulate the enzymes in the glucose production gluconeogenic pathway, particularly PEPCK, phospholynyl pyruvate carboxykinase. That's on the exam. Did you know that? Right after this, we're having an exam, and that enzyme's going to be on the exam. I'm just kidding. That's the first enzyme in the gluconeogenic pathway, and it's upregulated not only by glucagon, but corticosteroids. And corticosteroids also activate glucose 6-phosphatase, which is the enzyme that removes the phosphorus compound and puts glucose into the plasma. And that's a nice way to jumpstart glucose production if the baby persists in having low glucose concentrations despite treatment, but you can't find any other metabolic problems. Glucagon stimulates glycogenolysis. You can give it intramuscularly. Problem with it is it'll raise the glucose, but then its effect goes away. It doesn't last more than minutes, and so you end up hypoglycemic all over again. Diazoxide is nice for those rare infants that have the potassium channel disorders. These are infants with genetic complications, and it becomes part of a long-term endocrinological workup and treatment, so enough of that. Somatostatin, long-acting somatostatin or octreotide does the same thing. And finally, if these babies have pancreatic tumors with excessive insulin production, or they have these potassium channel disorders, you can go further on later in these children's lives to subtotal pancreatectomy. The problem with that, of course, is that you produce permanent diabetes. If you have symptomatic hypoglycemia that's severe, baby's seizing, is comatose, very low glucose concentrations, you're obligated to start an intravenous. I always recommend, if the baby's a brand new baby, of using the umbilical vein because you can get it in very quickly with a catheter and treat the baby immediately. Many of these babies, it takes a long time to find a vein, so go ahead and just put in an umbilical vein catheter. This is the prime 200 milligram per kilo of glucose mini bolus that Dr. Pildes and her group published now a long time ago, 1980. That's the constant infusion approach. That's the primed constant infusion approach. I recommend the constant infusion approach most of the time because you can see that by 10 to 15 minutes, its values are pretty close to those of the primed constant infusion, and this avoids overshooting, producing sudden hyperglycemia. And if you don't know the baby has a potential for hyperinsulinemia, you might have stimulated insulin production and have the same recurrent problem all over again. By just doing a constant infusion, you tend to avoid that risk. So especially if you know about hyperinsulinism, baby's infant of a diabetic mother, use the constant infusion approach. Is there any evidence with modern imaging studies that brain damage actually occurs? Nobody knows because no one's doing a controlled prospective study. But there's more evidence now that the animal literature may not be complete. The animal literature shows that severe, sudden, and then prolonged hypoglycemia, producing seizures and coma and that sort of thing, leads to occipital white matter damage. And those are perfectly obvious on many different kinds of studies. And those were seen in newborn infants who were allegedly only hypoglycemic with seizures and coma as the cause of their neurological problems. This particular study was from the Frances Cowan's group at Hammersmith Hospital in London, and for the first time, when she looked at a group of infants, and these were newborns to slightly older infants admitted from the emergency room into the hospital for imaging studies and medical care. They were admitted because they had significant illness. they were very sick, and they included infants with seizures and infants with coma and infants with brain trauma and infants that had intrauterine growth restriction and so forth. So this was by really not a normal group of infants at all. So whether the hypoglycemia that they noted and therefore did an imaging study under their research project for was the cause of these kinds of abnormalities, they couldn't say, and no one could. But for the first time, they noticed things like white matter injury that was diffuse, not just in the occipital region. For the first time, they noticed hemorrhage, uniquely reported now, associated with this low glucose concentration, but again, probably, or at least uncertain, whether that was causal or not. And the patterns were much more varied than had been previously seen, occurring in the basal ganglia as well as diffusely throughout the cerebrum. So a much more robust picture of potential neurological injury in babies who also have hypoglycemia. Whether there's any causal relationship or not, we don't know. And I'm suspicious of this because the animal literature is much clearer in showing just occipital injury. I'm suspicious of that too, because if glucose is so important for cerebral energy metabolism, then you would expect the brain all over to be affected, not just the posterior occipital region. So I think there's a lot to be learned from modern imaging studies and continued animal research. What about this issue of persistent or recurrent hypoglycemia? These are the babies with the metabolic disorders, particularly the hyperinsulin disorders. These are the ones that should never go home until you are certain that transient hypoglycemia that you'd identify when it's in a symptomatic infant in the newborn care unit, particularly just the well baby nursery. When you identify these infants, you don't send them home until they've established normal feeding, fasting cycles, and maintaining normal glucose concentrations. These are infants you should keep for an extra day or so. Where we run into problems in the United States is that for insurance purposes, both public and private insurance say if you're a perfectly normal mother with a perfectly normal delivery and your baby is healthy, go on home at 24, at the latest 36 hours. And we've come up with all kinds of complications as a result of that. So these babies need to be very carefully diagnosed, carefully treated, and not sent home, of course, until you're certain of the diagnosis. And many of these go on to endocrinology consultations. So that's the story. Recurrent, marked low glucose concentrations should always, those babies should always be kept in the nursery until the baby is perfectly stable. Establish full feedings before discharge. And then I want to bring one point to your attention. Always beware of the young mother who is trying to breastfeed for the first time, is uncertain in any way about her health, the baby's health, or the capacity to breastfeed, has any sign of illness herself, even if she says, I just don't feel well, and has limited home support. She's going home pretty much on her own. I won't say every single, but 90%, almost all of the cases that I deal with for legal issues of babies coming back to the hospital with low glucose concentrations and the question of neurological injury come from this group of women and their babies. There's nothing wrong with babies being breastfed, but the mother is at risk because there is very poor support. And if she doesn't produce sufficient milk, she's home alone and doesn't know what to do, and the baby gets hypoglycemic because the baby hasn't been fed. That's our failure for not being better physicians and providing better support for the young mother who's trying to breastfeed for the first time and has poor support and might herself be ill. Now, what about, and that's just to show you that there's long-term complications and they're very severe. The last issue, what about hypoglycemia in correlation with hypoxic ischemic injury? This has been studied in animal models. There is a direct correlation. The more hypoxia, ischemic injury you have to the brain, and the lower the glucose concentration associated with that or following that injury, the worse the outcome. There's only one clinical study in humans that I know of. I'm not going to go through the mechanisms. That's this chart. This study was a chart review, retrospective, term infants that had signs of hypoxic ischemic injury clinically, and they all had metabolic acidosis that was in the range we would call very severe, portending bad neurological outcome. And on admission, within 1 hour of life to the neonatal intensive care unit, the group of those infants in this group that had low glucose concentrations had a much higher odds ratio, 6.3, that was highly significant of having worse neurodevelopmental outcome. So the correlation between hypoxic ischemic injury and low glucose concentration is positive and it's strong. Now, does that mean that this low glucose concentration truly is adding to the neurological injury, either additive or even in some synergistic way? Well, we don't know. At the end of this article, which has never been really dealt with, the authors report it remains unclear whether earlier detection of hypoglycemia, such as in the delivery room, in this population, and they meant of the infants with hypoxic ischemic injury and acidosis, could modify subsequent neurological outcome. No one's done that study, no one will do that study, but what we should do is pay attention to babies, measure their glucose earlier when they had evidence of hypoxic ischemic injury. How do you manage them? You maintain a normal glucose. There's damage from hypoxic ischemic injury. That gets worse in an animal model with very high glucoses or very low glucoses on follow-on treatments experimentally. So keep the glucose concentration normal. And then I'll come back to just a couple of pictures from our friends here in Spain, from Barcelona, and note that it may be time for continuous glucose monitoring. Up to 12 days of life, and look at the number of cases they saw of hyper or hypoglycemia. So it doesn't just happen in the first day and then completely go away. It's more common in the first few days of life and then tends to disappear over time, but it's still prominent for some time after birth. Is it time? Well, we have no information about the clinical significance of episodes of low glucose concentrations and which should be treated or in which infants, so it's time for research. What glucose concentration and of what duration should be used as the lower limit? Same old problem, we don't know. So if you're using this methodology, you measure a low glucose with it, you still don't have evidence of what it means. So we do need more research. And there's danger that continuous glucose monitoring might be incorporated into clinical practice without knowing what these low glucose concentrations that you see episodically and maybe more frequently than you previously thought were in the case would eventually mean. And so infants might get treated that didn't need to be. And I worry particularly about the breastfeeding infants. So we need studies for research. I'll finish up with just quickly getting to rational thinking. This is the last slide that I want to show you. If you have a baby seen in long-term neurological follow-up clinic that has cerebral palsy, and someone says, well, you know, back at when this baby was born, it had a low glucose concentration. Could that have caused this cerebral palsy? Be very suspicious of that unless you find the following complications: that the blood or plasma glucose concentrations was extremely low, less than 1 millimolar, that it was low for long periods, hours, not minutes. Whether it's 2 to 3 hours or 1 to 2 or 5 to 6, no way to tell. The literature is complicated. That there are early mild clinical signs that then moved on to very severe clinical signs, and that they tended to disappear with treatment but then recurred. So that treatment showed that there was a glucose effect, so the problem was due to low glucose, but the problem got worse and the treatment was not effective. And that these were associated then with the development of severe complications of seizures and coma. And finally, whether there was associated recurrent hypoglycemia and problems such as hyperinsulinism or metabolic disorders of other kinds. So if you can put all of that together, you have a reasonable chance of saying that this baby might have had hypoglycemic injury. So I think you can get the point that I think serious, severe hypoglycemic injury is rare, and the reason it's rare is because it probably doesn't occur most of the time. And therefore, we are not so concerned that we think it's happening every day in our nursery. But the counter side to that is, if we knew what glucose was doing metabolically at any one time, we might be able to better assess what's going to happen long term. So I am very optimistic about keeping a very tight control over glucose concentration in a research fashion, and maybe only in clinical practice starting to use something like the glucose monitor, the continuous glucose monitor. So don't interpret glucose concentrations as always bad when they're low, but do pay attention to them and I think this is a great area for further research. Thank you. Couple of questions, time for a couple. Yes, sir.
Thank you very much, sir. I'm a little confused about just one point. You mentioned that if we are having a baby with a brain injury and blood glucose level, it's so bad for this baby. But the neurologists also, they say high blood glucose level is also very bad when you are having brain injury, asphyxia, I mean. So, what's going on?
Well, we all know that severe hyperglycemia by itself, if it's sudden, can lead to brain injury. Sudden change in the osmolality of the plasma from a hypertonic glucose infusion can produce cellular swelling, and that includes the endothelial cells, and you can get central nervous system hemorrhages or strokes, infarctions. Why does hyperglycemia, when you had hypoglycemic injury, add to that? That's a great question. There's a long story about this from animal literature. The problem happens to be, relates to a series of metabolic changes leading to acidosis, poor blood flow, and regional hypoxia. And these are fairly well documented in the animal models. I can't say that they actually occur in babies because we don't do that kind of a study. But we've done these in our own laboratory where we've taken a fetal sheep, for example, and made the animal hypoglycemic to the point where we had an abnormal electroencephalogram, and then we corrected with very high glucose or kept the glucose low or normalized it. And those that had the high glucose concentrations had areas of infarct spreading out from earlier infarcts. So propagation of infarct area, probably because, as I say, metabolic disorders, acidosis, low regional hypoxia, and poor blood flow, and then further cellular injury. So normalize the glucose, don't shoot for a much higher glucose, and normalize it expeditiously, but not so urgently that you produce a high glucose and then have to try to correct that again. Good question.
Thank you very much for this very clear-cut lecture, although you didn't give us a value under which hypoglycemia is thought to be. I would like to mention a very recent case in our department. We had a mother who had gestational diabetes and was treated, and the baby was normal. I can't remember exactly the weight, but it was about 3 kilos and 300 grams or something like that. We just controlled glucose because we thought that this baby of a diabetic mother, and the baby was totally asymptomatic, and it had 19 milligrams per deciliter. So we were very anxious, and we started an IV. We controlled it again, and it was not a mistake. We found it also in the laboratory, and we started an IV, and the baby would not go up. And we started with 10% dextrose, and then we went to 12.5 dextrose. And the baby still had low glucose. So we thought we have to go on with glucagon. And then I asked the pediatric endocrinologist in the pediatric clinic, and she told me, because this baby was actually 37 weeks, and she said, this baby, not only for surfactant, but for other reasons, it is considered a premature. And these babies that are 37 weeks and are babies of diabetic mothers, they have to start with corticosteroids before glucagon, as they lose sodium from their kidney if you give first glucagon. I didn't know that. So we started corticosteroids, and still the baby did not go up. And then we went on to glucagon, and it took 10 days in order this baby to normalize glucose levels. Now, I don't know whether this, what I said with corticosteroids before glucagon, I saw that you mentioned corticosteroids before glucagon. I don't know what is actually the right way, what we start with, and what about this sodium loss in babies that are 37 weeks and babies of diabetic mothers?
No matter how often I give this talk on hypoglycemia, there is always someone that comes up with a case that no matter what I said, it doesn't quite fit. But this is one that I hear about all the time, and we have it in our own intensive care unit. So there's several things about infants of diabetic mothers, which is really another whole lecture. But first off, these babies do tend to be born prematurely. There are reasons for that, metabolically, perhaps just their size in some cases. We often overinterpret their gestational age, even when we know they're born preterm, because of their size. So we think because they're bigger that they might be more mature, and we underestimate that their capacity for normal metabolism. So that's one problem. Second problem is that they may have, infants of diabetic mothers are highly variable in what insulin does. It does lower their glucose concentration in two ways. The first is to enhance glucose uptake by peripheral tissue. So that's going to have glucose utilization rate go up. The second is insulin suppresses PEP-CK and reduces glucose production by the gluconeogenic pathway, so that you reduce glucose production by the liver at the same time you're putting glucose into cells. And the balance of these two processes in babies can be quite variable. So some babies simply have more utilization capacity, and some have more sensitivity to insulin to shut off their glucose production. And why there's variability, I can't tell you. It's just that's nature. So some of these babies are simply going to be more at risk. And then you say, well, this is a big fat baby, has plenty of fatty acids, and therefore should be able to have plenty of alternate substrates. Well, if you have an alternate substrate, you don't need to produce glucose. But whether or not the substrate is capable of compensating with brain metabolism is really very uncertain. Some babies who are infants of diabetic mothers, the insulin suppresses lipolysis, and they don't have alternate substrate capacity. In others, the insulin does not suppress the lipolysis, even though it's activating glucose utilization and suppressing glucose production. So a large range among infants of diabetic mothers that we know exists, but we don't always know what's going on in an individual baby. So all I can say is that this is a common scenario. We see it frequently, and many of these babies, we simply underestimate their need for glucose, and we continue to underestimate, so it's a fairly common story. Minutes go by and we give the right amount of glucose. Maybe we even raise our glucose infusion rate. And as soon as I went through one of these cases in another nursery that I was consulting in, everything that I said they had already done. And I was pretty well exhausted with the whole process. And so I said, well, did you ever check your glucose infusion pump? And they did, and it was set somewhere on a half speed. So the baby was ordered for 10 milligrams per kilo per minute and was getting 5. So look at all possibilities in these sorts of cases, and don't think your equipment is always working properly. So I can't tell you in any one baby why an individual has these particular complications, but infants of diabetic mothers continue to be a major problem. And this is still with us, in fact, in many situations increasing because of the increase in type 2 diabetes in the population, added to by obesity and the risk for the high episodic swings of glucose, and that stimulates insulin production in the fetus, and then that carries over into the newborn.
Would you start with glucagon?
Yeah, as I said already, glucagon has, whether there's a sodium problem or not, isn't the issue. It's that it does this to your glucose, and then its effect is gone within a half an hour. So your glucose goes up, stimulates insulin secretion, glucagon goes away, and now you have a lot of insulin, and your glucose is suppressed, disappears, and you're hypoglycemic all over again. If you're going to stimulate the gluconeogenic pathway, corticosteroids work much better. Their effect is sustained, and you always plan a course of 2 to 3 days. Most of the time, you only need it for 2 or 3 doses, but we usually do it as a 2 to 3 day course and then taper it off, just so we don't run into the rebound problem. Oh, you can, but if you're going to do that, why not just infuse glucose and give corticosteroid? I just don't find glucagon very useful because IV glucose and corticosteroids work almost all the time if that's what you need to do, is just activate gluconeogenesis.
Thank you, Professor, for the lecture. I would like to ask, you mentioned the cohort from Imperial College, but to your knowledge, is there a cohort of asymptomatic hypoglycemic IUGR infants, or maybe a study about their neurodevelopmental outcome that can be attributed perhaps to hypoglycemia? And the second question is, if you have an IUGR baby below the 5th percentile, for example, that has blood glucose on the lower side, but not very low values, and this baby is absolutely breastfed. In view of the fact that there are no standard feeding patterns, and this baby might be fed every half an hour, every hour, how would you monitor the blood glucose in this baby? Would you insist on pre-feeding glucose monitoring, or every 1 or 2 hours, or how? Thank you.
First, I don't know of any cohorts of IUGR infants. That would be nice if there were more studies of these population-type studies going on. The unpublished study by Dr. Tin was just the same as the Lucas study. These were regular old preterm babies. In terms of the breastfed baby with transient low glucose, why did you know it was low? Because I wouldn't have measured it in the first place. Yeah, well, if it's IUGR, you have a different problem. So whether it's breastfed or not, if you have an IUGR baby, I think you really should be looking at the glucose concentration and encouraging the mother to breastfeed. And I think then you have to make a clinical judgment, and there are really no ways of saying which is better or which is worse. If the glucoses are low and the baby's getting symptomatic, you don't stop breastfeeding, just put in an IV, let the mother breastfeed, and carry on. One of the problems we have in our situation is that we have to admit those babies that are on IVs to our intensive care unit. Costs a lot of money, costs nursing time, causes the mother a huge amount of anguish, and doesn't change the outcome of the baby. It would be much nicer if we could do this in a setting where the mother could very comfortably continue breastfeeding while we simply make sure that the baby's glucose doesn't get to very abnormal levels and that we've corrected the symptoms. I wouldn't be surprised also that if you find a hypoglycemic baby whose mother is breastfeeding and the baby is IUGR, that maybe those glucoses are the abnormal neurological signs that start coming along or due to something else and not the low glucose. So consider IUGR a separate problem. Yes?
About Bill Hayes' quick and easy guidelines. The picture that we check the whole blood. In our NICU, we check the glucose in whole blood. What do you say about this?
Oh, that's okay as long as you're consistent with it. Plasma glucoses are about 20%, 10 to 20% higher than whole blood glucoses. So it doesn't matter whether you're measuring whole blood or plasma, it's just that you measure it consistently one way or the other, and so you know what you call low. So if we say a plasma glucose of 45 is low, that would translate into 35 to 40 whole blood. So just pick whatever way you're going to measure it. The reagent strips, while you put whole blood on the reagent strip, they're really measuring plasma glucose. If you measure whole blood glucose, you have the whole blood simply diluted by the red blood cells. And most of the instruments will have if you put it in an actual instrument, they hemolyze the red blood cells. And red blood cells do contain some glucose, but not as much per gram of red cell as per gram of plasma. So you still end up diluting your plasma glucose a little bit. So it doesn't matter to me which you measure as long as you're consistent with it and just set your own lower limits just for practical clinical reasons.
So in whole blood it is lower?
Yes.
By 5?
By around 10 to sometimes as much as 20% at the very high hematocrits. Good, thank you very much.